In this video, we'll talk about the AV nodal reentry tachycardia, which is the most common form of SVT. Actually, it is also the most common cause of palpitation in patients with normal hearts. If the patient does not have any heart problems and they present with palpitation, they have likely having AV nodal reentry tachycardia or AVNRT. And usually speaking, when we are talking about anything that is related to the nodal, the AV node, they are typically paroxysmal and they could happen out of nowhere spontaneously or upon provocation because of something like caffeine, alcohol, or like using of salbutamol or for like nebulizer or IV salbutamol for asthma. Sympathomimetics as well, like cocaine and amphetamine can induce AVNRT as well. And generally speaking, they are more common in females. Around 75% of the cases occur in female, and they usually occur in young and healthy adult, but also can occur with patient with chronic heart disease. The range of the heart rate is almost always between 140 and 280. It is very unlikely that AVNRT will present with heart rate less than 140. This is important. This is high yield. This is very important. If a patient heart rate is 120, it is very unlikely to be an AVNRT. It is usually very high, like you're reaching 170, 180, and so on, up to 280. It's unlikely also to exceed 280, so it's very rare to presents with 300. The symptoms that patient can develop is sudden onset palpitation because it's paroxysmal. Sometimes they have chest pain, especially if their coronary is already clogged and they have coronary artery disease. They can present with dyspnea as well because the heart is too fast, is unable to eject all the blood from the lungs, so the fluid will and the blood will accumulate in the lungs. Also, the patient will have anxiety because of the palpitation itself. And sometimes the patient will develop polyuria because the atrium is contracting very fast. So it will get high pressure because it's contracting very fast because of this electricity. And because of the increase in atrial pressure, this will stimulate the production of atrionatriuretic peptide that can cause polyuria. So after these episodes, the patient will have polyuria, and this is rare actually. All right, so let's talk about now the pathophysiology, how the AV nodal reentry tachycardia happens. And actually, the name implies a lot. It is actually a functional reentry. It is something functional, structural. This is very important because in contrast to the AV reentry tachycardia, which is not involving the nodal itself, there is a bundle of Kent. There is an accessory pathway in the heart causing the reentry of the electricity. Okay, so AVRT is a structural problem, but AVNRT, the node itself has this problem. So the electricity is going to the ventricles, coming back from ventricles, the atrium, and going so on. So we have a short circuit here of electricity going through the AV node itself, the node itself, causing this reentry. So it is a functional reentry. Okay, this is really very important because in AV nodal reentry tachycardia, the patient will have a normal heart structure. In contrast to the AVRT, which is the AV, atrioventricular reentry tachycardia, those patients will have an accessory pathway called bundle of Kent. This is something else. We will discuss it in another video. All right. So we are talking here about a functional reentry. So how we can understand the functional reentry? Let's see here. Okay, this is the most important slide here. Let's have a look at the AV node. This purple circle is actually the AV node. Okay, now in the AV node itself, there are two pathways. One pathway is called the alpha pathway, which is the slow pathway, as you can see here. It is very slow. So if like electricity is traveling through this, it needs more time because it is like, as you see, it's zigzagging, it's not straight. So this is the slow pathway. And the slow pathway is actually very slowly conducting, but it has a very short refractory period. Okay, so it's slowly conducting, but the refractory period is very short. In contrast to the fast pathway, which is the beta pathway. The beta pathway is very straight, so it is very fast. Electricity will travel really very fast. But because of this fast conduction, it has a long refractory period. That being said, let's talk about the normal physiology. In normal physiology, the SA node will give us electricity. This electricity will reach the AV node. And once the electricity is here, it will go through the fast pathway as well as the slow pathway. This is the normal thing. But at the end of the AV node, the fast pathway will reach first, right? And it will conduct a bundle of Hess and go through this. So this will cancel the electricity that is coming by through the slow pathway, because that is already conducting to the bundle of Hess. Again, let's talk about the normal thing. During normal sinus rhythm, I have a normal sinus rhythm. The electrical impulse that is coming from the SA node will travel down on both pathways simultaneously together at the same time. But the impulse will be transmitted down through the fast pathway very fast, because this is the fast pathway, and will enter the slow pathway from down here and will cancel the electricity that is coming with the slow pathway. So the slow pathway is always ignored in the normal cases, a normal scenario, okay? So always the conduction to the ventricle will be through the fast pathway or the beta pathway. This is the normal thing. Now, let's talk about a patient who is going to have AV nodal reentry tachycardia. Let's see what is going on. Now, what is happening here is, let's say, now the SA node generated an impulse. This impulse traveled through two pathways, but it reached here faster because of the beta pathway, the faster pathway, and it canceled the electricity from this pathway here. Now, at this exact moment, let's say that this patient will have a premature atrial contraction, PAC. Foci of the atrium just generated some electricity. So the electricity will come here. Okay, this is the brand new electricity. Let me change the color and make it bold. Okay, so the electricity is generated from anywhere in the atrium, and this electricity is coming to the AV node. Now, in the AV node, we remember that the fast pathway is having a long refractory period. So this is in refractory now because it is already conducted. It has already conducted an impulse. So it is in refractory. So this electricity now have only to travel through the slow pathway. Okay, and at the time that it reaches the end of this pathway, the fast pathway is already outside the refractory period. So this impulse will travel through the fast pathway again to up. And for sure, guys, it will go down. It will contract the ventricles. So it goes down to the bundle of Hess, contracting the ventricle, and some of the electricity will go back retrogradely through the fast pathway. When it reaches here, some of the electricity will go to the atrium, causing retrograde, a contraction of the atrium. So will give me a P wave, retrograde P wave, and will go through the slow pathway again, reaching the end of the slow pathway, contracting the ventricles, and go back up the fast pathway, contracting the atrium, and going down through the slow pathway, contracting the ventricle, going up through the fast pathway, contracting the atrium, and so on. And because the AV node itself is very small, it's a very short pathway, like I just maximize the picture, I just make it bigger, but it's actually very small. So this electricity, because of this, the impulses are getting retrogradely. Okay, the tachycardia will happen. Okay, so the tachycardia will happen because of this. Okay, so this is the pathway, or this is the mechanism that is going on. Okay, now, as being said, this is the mechanism that I'm talking about. So how we can give a terminology for this pathway, for this pathophysiology. Now, let's see, by convention, I have two pathways. I have the fast pathway. This is the slow pathway. And this is the fast pathway. Okay. From the mechanism that I just mentioned, which pathway is actually exciting the ventricles? It is the slow pathway, right? So it's called the slow dash. And which one is exciting the atrium is the fast pathway, because the electricity is going retrogradely to the atrium. So which is contracting exciting the atrium? The atria is actually the fast pathway, so it's called the slow fast. And this is the most common mechanism. This is like 90% of AVNRT. It's called slow fast or typical AVNRT. as I just mentioned here or discussed with you guys. Okay, this is the most common type. Okay, now that's being said, just hold on a second. Now, when the slow pathway is conducting the electricity to the ventricles and the ventricles are contracting, this will give me the QRS complex, which is the R wave, right? And after that, the fast pathway will conduct electricity upward into the atria again and will give me a retrograde P wave. And so the P wave will become after the P wave will come after the QRS complex. Okay, most likely this P wave will be buried inside the QRS complex and it will not be evident. So the P wave is actually will come either buried inside the QRS complex, so I can't see it, or it will be just after the QRS complex, or sometimes it comes before the QRS complex because there are too many types of, or the major 3 types of AVNRT that we're not going to discuss. Just like, remember that we have 3 pathways, 3 different types of AVNRT. The most common is the slow fast pathway that we have just discussed here. All right, let's talk about the ECG features. What are the ECG features? First of all, the rhythm will be always regular because, as we said, the AV node always having regular rhythm. And as we discussed the pathophysiology, it is a circuit. It is a circuit of electricity going back and forth. So it will be always regular. The heart rate will be between 140 and 280. Very unlikely to be less than that. And it will be likely narrow. Why I said likely narrow? Because if a patient is already having a bundle branch block or accessory pathway or even an apparent conduction, the QRS complex will be wide. So again, the wide complex versus narrow complex does not mean anything here. Okay, and the most important part, if I can see a P wave, if it is visible, because as I mentioned, in a slow fast type, which is the typical type, most likely you can see the P wave. But if you see a P wave, it will be a retrograde P wave, meaning that it is going from down, if this is the heart, and the AV node is here. Okay, the electricity is actually not going from the normal from SA node to AV node like this. It will go from the AV node back up. So the inferior leads, the lead 2, 3, and AVF, the electricity is going away from them. So the P wave will be inverted by definition. Okay, so if you see a P wave, it should be inverted. And this P wave could be buried within, so you cannot see it, or visible after the QRS complex, or very rarely it's before the QRS complex. This is the least likely type of the AVNRT, to have a P wave before the QRS complex. Okay, so these are the features that you have to know for AVNRT. So they are pretty simple. If you have a regular heart rate between 140 and 280, and this number is really easy to remember. It's just like multiply this number by 2, you will have this number, okay? And the B wave either inverted or absent. Inverted or absent. Again, inverted or absent. So you look at the lead 2, 3 AVF, it will be inverted or absent at all. Okay, other features that we can see in AVNRT, but they are not from the criteria to diagnose AVNRT. You can see them or you can't. The first one is ST depression. And this is actually rate related because whenever we reach a very high rate, the ST segment will depress by itself. And this does not mean that the patient has coronary artery disease. It does not mean ischemia at all, okay? So this is really important. And number 3, you will see something called the QRS alternance. Because the electricity is going back and forth, some electricity impulses will be high voltage and some of these will be low voltage. So you will feel like a phasic variation in the QRS complex amplitude, okay? And remember, there is an electrical alternance that is seen in cardiac tamponade. In electrical alternance, the QRS complex amplitude itself is low and there is alteration. Here, the QRS complex amplitude is normal, but there is alteration. And this alteration because of the variability of the voltage that is reaching the ventricle each time. All right. So these are the features. This is very important. Again, we talked about the slow fast, AVNRT. This is the most common, and this is typical. And just like a summary, just remember we have 3 types of AVNRT. We have the typical, we have fast, slow, and slow. How can you distinguish between them? If you don't see any P wave, this is typical. If you see a P wave just after the QRS complex, and it has to be inverted in lead 2-3 FF, this is fast slow. This is the opposite of the most common one. And if you see the P wave before the QRS complex, and this is really very rare, that means only the slow pathway is working. It's called slow. This is not very important. Now, regarding treatment, if you have a patient with AV nodal reentry tachycardia, the mainstay treatment is actually the adenosine. Sometimes you can try vagal maneuver, like vagal stimulation, carotid massage, or rubbing the eyes, coughing, and all these things can help. The mainstay treatment is actually the adenosine to block the AV node and stop the circuit. You can use beta blockers like bisoprolol, metoprolol, whatever, and you can use calcium channel blockers. You can use also amiodarone if the patient is healthy and he is young. And sometimes we use catheter ablation if the case is refractory and recurrent. DC cardioversion is really rarely used because those patients usually are hemodynamically stable and they will never have hemodynamic alteration. Okay, let's talk about some examples. Okay, let's look at this EKG strap. This is an EKG. If we look here, first of all, it is narrow complex. Does it count for us? It does not matter anything, right? Because another patient could have the same EKG, but he has a left bundle branch block or right bundle branch block, and the QRS complex will be wide. So narrow versus wide is not something important. Now, what it is important is that is regular. Like you can see, it's almost two large squares between each are waves, right? So it's almost 2. And so the heart rate is 300 divided by 2 is 150. Okay, so the heart rate is 150. So it is within the range. It is regular. I can see it's regular here. And I can't see any P wave. But there is no P wave before and nor P wave after. This is the T wave. No P wave, this T wave, no P wave, no P wave. So this is typical AVNRT. This is a case of typical AVNRT. Next step is to give either vagal maneuver or do an adenosine challenge. One more example of this. Okay, this is another example of the patient. And we can see that this is pretty regular, right? It's almost like 1.2 large squares in between, 1.2 or 1.5 all the time. And you can actually count all the QRS complexes, which is around 32 here, multiplied by 6. So the heart rate is 192, which is again in the range of AV nodal reentrant tachycardia. It is regular, and I can't see any P wave. There is no P wave. This is a T wave. QRS complex T wave, QRS complex T wave, QRS complex T wave, and etc. Number 3, and you can see the ST segment depression. This is a feature of AVNRT, but it's not needed for diagnosis. And actually, this does not necessarily indicate that patient is having myocardial ischemia, because this patient heart rate is 192, which is really very, very fast, okay? So it only means that the patient has rate related. And once you treat this tachycardia with adenosine or beta blocker, that ST segment depression will likely resolve when the patient is in sinus rhythm. All right, so I think this is all about AVNRT, and thank you.